Hello dear students, good afternoon. So I am here again to take another session of the recall of FMGE July 2024. In the first session we have discussed anatomy, PSM, medicine, surgery, obstetrics and gynecology. And in today's session I'll take the remaining subjects. So we'll start with physiology, and one of the question was about the smooth muscles, and it was asked like which component is absent in smooth muscles, right? So there are few components which are common in smooth muscle and skeletal muscle, like actin, myosin and tropomyosin. These are common in skeletal muscle as well as smooth muscle. And troponin, which is a component of skeletal muscle, is absent in smooth muscle, right? So troponin is not present in smooth muscles, right? So we can, if we look at the diagram, we can see the actin, we can see the myosin, and we can see the tropomyosin as well. Now just few words about tropomyosin, because usually what happens, like if we discuss the skeletal muscle part in relation to the skeletal muscle. So suppose this is thin filament, that is actin, and on actin there are active sites, right? These are the active sites. And then lower down we have the myosin heads, myosin head, and myosin head has a tendency to bind to these active sites, and so that muscle contraction can take place. Now to avoid contraction during rest, these active sites are covered by a protein, and that is known as tropomyosin, right? So this tropomyosin covers these active sites, and it makes sure that the myosin head does not attaches to the active sites, because the moment it attaches to the active sites, it will result in muscle contraction. Just to avoid contraction at rest, this binding of myosin head with the active sites of the actin is prevented by tropomyosin. So this is the usual picture, and this is what is the role of tropomyosin. So troponin, which is present in skeletal muscle, is absent in smooth muscles. And then there was one more question related to skeletal muscle only, like what is the part where the calcium binds to result in smooth muscle contraction, right? So we know that in a case of skeletal muscle, there are troponins, right? So there are troponin, and the calcium, it binds with these troponin, and this displaces the tropomyosin, exposing the active sites so that the myosin head can bind to it, and then this results in muscle contraction. Now this is for skeletal muscle, and here in skeletal muscle we have troponins, right? So in skeletal muscles we have troponin, but that is not the case in smooth muscles, because we just discussed that smooth muscle don't have troponin. Now what does smooth muscles have in place of troponin? And that is calmodulin. So that is calmodulin, and like you can just remember cal here and cal here, just for that purpose, right? So if we take the basic differences between the smooth muscle and the skeletal muscles, there are a couple of differences which you should know. Number one is the point of binding of calcium. In smooth muscles, it binds to calmodulin. In skeletal muscle, it binds to troponin. right? So that is one important point. In skeletal muscles, we have troponin. In smooth muscles, we have calmodulin, right? And that is the protein where calcium binds. Number one. Number two, the source of calcium, right? So in smooth muscles, there is increase in cytoplasmic calcium, whereas in case of skeletal muscle, there is increase in calcium, which is coming from sarcoplasmic reticulum, right? So this is very important. Sarcoplasmic reticulum for skeletal, and this is calcium in smooth muscles. It is coming from interstitial fluid. So the source of calcium also differs. So number one, the source of calcium, and the number two, the place or the protein where the calcium binds in case of skeletal muscle and smooth muscles is totally different, right? So please remember at least these two important differences between skeletal muscle and smooth muscle in terms of muscle contraction. Okay. Then there was a question about the physiological response when a person is exposed to high temperature when he is exercising vigorously. So in simpler words, the question is about exposure to hot environment, right, or heat. So whenever there is the body is exposed to hot environment or when there is excessive heat around, so body will try to lower down the temperature, right? So body will try to lower the temperature. This is thermostat. And how it will reduce the temperature? By sweating and vasodilation, right? So this is sweating and vasodilation. So this a basic thing which we have discussed over the years. Whenever there is exposure to, like, if there is exposure to heat or cold, if there is exposure to heat, there will be sweating, right? And when there is exposure to cold, there will be shivering. That is muscle contraction, which will generate heat so as to increase the body temperature. In case of heat exposure, body will sweat so as to lower down the temperature, right? So this is the thermostatic mechanism. So whenever someone is working vigorously and especially at high temperature, there is heat all around, so body will try to lower the temperature by sweating associated with dilatation of skin, right? So this is the thermostat mechanism. So if there is high temperature, there is sweat glands which produces more sweat, and the arterioles, they dilate. So there is vasodilation, right? So exposure to high temperature. Now, the oxygen sensitive channels of peripheral chemoreceptors, they respond to, and these are actually the potassium dependent. Now let us discuss what are these peripheral chemoreceptors. Now, as the word suggests, chemo is something related to chemical. Receptors are actually the sensing part, and when we say peripheral, we are discussing the aortic and the carotid bodies, right? So the peripheral chemoreceptors, they are the carotid, they are present in the around the bifurcation of the common carotid artery and the aortic arch receptors, right? So they are very sensitive to reduction in partial pressure of oxygen. These are actually peripheral chemoreceptors, right? We do have central chemoreceptors as well, which are in brainstem, especially in medulla, and they are sensitive to increase in partial pressure of carbon dioxide, which correlates with pH as well, right? So central in PCO2, and peripheral, which are actually in the aortic and carotid bodies, which are sensitive to, especially sensitive to the fall in partial pressure of oxygen and also increase in partial pressure of carbon dioxide, right? So these are the chemoreceptors. And peripheral chemoreceptors, especially these are related to potassium ions. Okay. Now, the next question was about maximum water absorption in kidney. The answer, I think most of you must be knowing, it is proximal convoluted tubules. So whether there is presence of vasopressin or whether there is absence of vasopressin, it doesn't make much of difference. Answer has to be always and always proximal convoluted tubule, right? So maximum water absorption, and not only of water, maximum solutes are reabsorbed back in PCT. But here you should remember one more thing, like there are few things which are 100% reabsorbed, right? So one is glucose and second is amino acids, right? So these are 100% reabsorbed in PCT, okay? So this is in PCT. And other substances like potassium, bicarbonate, water, they are reabsorbed somewhere between 60 to 80%, but 100% resorption for glucose and amino acids in PCT. I think this is a very basic question about the value of GFR, and everyone can answer it. So GFR, the value is 125 milliliter per minute. Okay, so that is very basic question. Now, another question was quite interesting, and it was about the factors which will affect the amount of GFR. So the question was about a condition which will increase GFR. So this was in relation to the afferent arteriole, efferent arteriole, and Bowman's capsule. Now, you should remember a couple of things. Suppose this is the afferent arteriole, this is the efferent arteriole, right? So efferent arteriole is taking blood away from the glomerulus, and this is bringing the blood to the glomerulus, and this is all then the efferent arteriole. Clear? Now, if the blood flow is more in afferent arteriole, means if more blood is going like this, there will be increase in GFR. Okay, and if there is less blood which is going through the efferent arteriole, that will also promote GFR. Similarly, if there is less blood flowing through the afferent arteriole, that will decrease GFR, and if there is more blood flow through the efferent arteriole, that will also decrease GFR. So these are few points related to afferent and efferent arteriole. Now, if there is increase in hydrostatic pressure in the Bowman's capsule, that will decrease GFR, right? So if there is increase in hydrostatic pressure, this will reduce GFR, right? So this will reduce GFR. So if you look at the options here, increased renal perfusion means more amount of blood is going to kidneys. That is more amount of blood which is flowing through the afferent arteriole. So as I told you before, if the blood flow is more, it will increase GFR, right? So in terms of, okay, we can just check in the image, right? So if there is increased blood flow across the afferent arteriole, if you say this is the afferent arteriole, okay, and if there is amount of blood flow which is more through the afferent arteriole, that is because of, you can say, renal perfusion, so that is again going to increase GFR. Then the state of vessels also affect GFR. If there is vasodilation of afferent, it will promote more blood flow to glomerulus, so GFR will be increased, right? GFR will be increased. Similarly, if there is efferent arteriolar vasoconstriction, so if we see here, this is efferent arteriolar constriction, that will decrease the, and that will increase the GFR, right? So that will also increase the GFR. So if we just summarize it here, if arteriole, and then so if it is, can just point out two things in terms of vaso, is this constriction or dilatation, right? So we write vaso constriction, dilation. Now, if there is vasoconstriction of afferent arteriole, that will reduce the blood flow to the GFR. So this will decrease GFR. If there is vasodilation of the afferent arteriole, that will promote more blood flow to glomerulus, and that will increase GFR, right? Similarly, if there is vasoconstriction of efferent arteriole, that will leave the blood in the glomerulus for a longer period of time, so GFR will increase. And if there is vasodilation of efferent arteriole, that will promote outflow of blood from the glomerulus, and that will decrease GFR, right? So this is the equation or the table which you should remember in terms of the state of the vessels of afferent or efferent arteriole, right? So, and in simpler words, you can remember it is just opposite. Afferent arteriolar vasoconstriction decreases GFR. Efferent arteriolar vasoconstriction increases GFR, right? Similarly, efferent arteriolar vasodilation increases GFR, but efferent arteriolar vasodilation decreases GFR. Okay, so this is, you should remember. And if the efferent arteriole is dilated, this will increase renal blood flow, what you call renal perfusion, right? So this is going to increase GFR, right? So please remember this thing. So this we have already discussed. If there is increase in resistance of afferent arteriole, that will decrease renal blood flow, and if the renal blood flow is less, GFR will be less, right? If there is decreased resistance of efferent arterioles, that will promote more outflow of blood, so this is again going to decrease GFR. Clear? So just remember this, and these are actually opposite to each other. Vasoconstriction in one promotes GFR, whereas vasoconstriction in another decreases GFR, right? So it depends in which vessel you are talking, whether it is the afferent arteriole or you are discussing the efferent arteriole. Okay? So please remember this, a very basic concept, and if you get to know the concept, you will never mark it wrong, right? So the next question is about U into V into P in terms of renal physiology. This explains clearance. So this is U, V and P. Now the word U stands for, if we are taking any substance, sometimes usually we discuss the things in terms of creatinine, right? So if we are discussing creatinine, for example, then if I write the word U, this is actually U, right? And UC will be written as the concentration of creatinine in here. So that is UC. Okay, then the alphabet B is the volume of urine, the total volume of urine at that given period of time, right? So this is total volume of urine. This is volume of urine, and then P is, or in fact, this is PC because we are discussing creatinine. So this is the concentration of creatinine in plasma, or what you say, blood, right? So this is how we are using this formula, and this gives us idea about the clearance of the substance in consideration, right? So Q V upon P, that is clearance of one particular subject, okay, or substance, sorry. So this is how we calculate the renal clearance of any substance which is under consideration. So what is the volume of urine total, and what is the amount of that substance in the urine divided by the amount of that substance in. Now then, a very important concept about ABG analysis. So here pH was given, PCO2 was given, and although PO2 was given, but we are more interested in evaluating the bicarbonate, right? So the normal value for pH is 7.35 to 7.45, right? So if any value is less than 7.35, you will call it acidosis. Yeah, so I think most of you must be knowing this already. And looking at the question, the pH here is 7.1, so that is acidosis. Now there are two ways in which acidosis can develop. One is respiratory and another is metabolic. Right? So there are two ways. Now, when we will say respiratory will be said when PCO2 is more than 45, because the normal value for PCO2 is 35 to 45, right? So this is normal. So if the carbon dioxide, if the PaCO2 is more than 45, that is respiratory acidosis. Now, metabolic will be set when the bicarbonate levels would be less than 22, right? Because the normal is somewhere between 22 6. Any bicarbonate value less than 22, that will suggest that the condition is, the metabolic reason is there for acidosis. Now, if you look at the question, the bicarbonate level is 16, right? So here the level is 16, and that question, so it favors the concept of metabolic acidosis, right? So this is how you can simply evaluate the ABG values, and you can reach up to the answer whether it is respiratory acidosis or metabolic acidosis, right? So this is straightforward, simple question. Now there was one more question about an hormone which is increased during the period of stress, starvation, or deep. So the hormone which increases, especially during the, if you know about the deep sleep, especially NREM part, you would know that it is growth hormone, right? So this is the pulsatile, or you can say diurnal variation, you can say, of growth hormone, and you can see there is a peak early period of sleep, right? So this is NREM sleep, especially, right? So this is growth hormone, and you can see a peak somewhere around 12 midnight or 1 a.m. So that is typical of growth hormone, and it can also increase during stress or exercise, right? So that is growth hormone levels. It varies with sleep or activity, right? Then there was one question, and it was like histology based question, and here microscopic picture was given, and then there was a specific label on one layer, and it was asked like which hormone is released from this particular layer. Now looking at the options like mineralocorticoid, glucocorticoid, then adrenaline or androgen, you can say that this is a histology of adrenal gland, right? Because all the hormones whichever are given, they all belong to adrenal gland. Now adrenal gland has two parts. One is cortex, and the inner one is medulla. Clear? So we can see this part is outer and this is right. So medulla is inner and the cortex is outer, right? So this all area, right, if I just mark it like from here till here, this all area is adrenal. This is, and this all area is the medulla. Okay, guys, medulla. Right now, the cortex, the whole cortex has three layers, and I believe most of you must be remembering that mnemonic GFR, which is a very commonly taught mnemonic. So we just add the word zona. So one is zona marmosa, second is zona fasciculata, third is zona, remember the mnemonic ZFR, and what is being secreted here, this is corticoids and this is sex corticoids. Clear? And from medulla, I think most of you must be knowing that it is the catecholamine, adrenaline, noradrenaline. So this is how we can use the hormones which are produced from adrenal gland. Now coming to the question, what actually the question is about. So the question is asking you about the middle layer. Okay? So this is, and from the description now I think all of you can answer what is the middle layer and which hormone is secreted from the middle layer, right? So the answer would come out to be right. So this is how, because most of you must agree that it is not easy for us to evaluate the histological slides that easily, right? So, but yes, if we can apply the concept, the theoretical concept, we can definitely reach up to a better answer, right? So this is how we can simply apply the concept about the layers and the hormones which are secreted from them, and based on this concept we could say yes, since the middle layer is zona fasciculata, so the hormone which is produced from that is glucocorticoid, which will be the answer here. Perfect. So this is quite simple. Now primary hypothyroidism we have already discussed in the previous session. Here primary means that the pathology is in thyroid gland. Clear? If there is thyroid gland pathology, obviously there is low T3, low T4. Now there is low T3, low T4. There is a feedback mechanism, the anterior pituitary, and this will tell the pituitary to release more of TSH so that this TSH can stimulate thyroid to increase the release of T3 and T4, right? So for primary hypothyroidism, the answer would be, I think there should be some change in the options because two options are almost same. So Anyway, you can take elevated TSH, low T4, right? And you can change any of the option here. You can keep it like this, low, and you can keep it elevated, right? So this way your answer would be option A. Okay. So this is primary hypothyroidism, low thyroid hormones, increased, elevated. Okay. Next question. So this concludes the physiology segment. Now we will start with the biochemistry part. And there might be some overlapping of questions in different subjects, but I don't mind that, because this way we are going to repeat the questions in a in a different format maybe. So that is just a kind of revision for us. So again, we are having a question which we have just discussed in physiology. So it was about ABG report, and here the pH is 7.16, bicarbonate is 9, and CO2 40, right? So again, if you apply the concept, pH any value less than this is acidosis, 4 is alkalosis. Clear? If you look at the question proper, the pH is 7.16, so which is actually acidosis. Once I said if there is acidosis, we have to rule out whether this is pyrethry or whether it is. What you will do, you will count the, you look at the values of the PaCO2 and the bicarbonate, right? So for respiratory, you have to check PaCO2, which should be more than 45, and for metabolic, you have to check bicarbonate, which should be less than 22. So looking at the question, the PaCO2 is 40, so that is absolutely normal, but bicarbonate is 9, which is less, right? So this is 9 here. So we can say that the question is metabolic acidosis, right? So that is metabolic acidosis. I think you can get it now. So that is, now there is one more question. It has been already discussed in surgery part. Here a child is neonate is having recurrent projectile vomiting. Now the age is better around 4 weeks, because that is the time at which it usually manifests, right? So recurrent projectile. Projectile means the vomitus is being ejected with a force and it falls at a distance from the body, right? So if suppose if the subject is somewhere like this, the projectile will be something like this. Okay, so this is, yeah. Then non-bilous. It means the obstruction is proximal to opening of, let's see, there is the bile. If the obstruction is proximal to that, obviously there will be no bile in the vomitus. So this is very suggestive of the diagnosis of infantile hypertrophic pyloric stenosis. Clear? Hypokalemic, hypochloremic metabolic, right? So this is quite clear question and one of the important concepts which you should know. Now, there is one anti-cancer drug, that is methotrexate. It was asked like, what is the mechanism of action? I think most of you must have heard about methotrexate, which is given for choriocarcinoma or molar pregnancy, right? So choriocarcinoma or molar pregnancy. Clear? This is one important thing, right? We should exclude this, better choriocarcinoma, right? So which can come out of that is gestational trophoblastic neoplasia. Now, what is the mechanism of action? It inhibits one enzyme, that is dihydrofolate reductase. It inhibits dihydrofolate reductase. Therefore, it hampers with the synthesis of DNA. Okay, so this is the mechanism of methotrexate. And since methotrexate is very toxic, so sometimes we have to give, should be given with polinic. It should be given with acid, which is also known as glucovorin rescue factor, right? So this is very important for uh, methotrexate. Just remember this much. So it inhibits the enzyme dihydrofolate reductase. Sometimes you might short forms. So this is dihydrofolate reductase. Now, there was another question about, again, from a very important topic, and this was like a child was having hepatomegaly, right? So it's a 3 months baby which is having hepatomegaly, that is increased liver size, and this was associated with cataracts in both the eyes. Apart from that, the child was lethargic and hypotonia. Now, which enzyme deficiency is more likely here? Now, the moment you think of cataract, you can think of galactosemia. Clear? The moment you think of cataract in a 3-month-old baby, you can think of galactosemia. Now, galactosemia can be because of a couple of enzyme deficiencies, and especially the ones which you should remember. One is the galactokinase, and second is the galactose 1-phosphate uridyl transferase, right? So this one is the important one, and of course this can also be considered, but how you will differentiate which one will be the answer? So here you have to look at the options. Like if I say correct, right, and if I write the enzymes here, galactokinase deficiency and deficiency of galactose 1-phosphate uridyl transferase. GALT. Second thing is hepatomegaly. That is a very important consideration. Now, in a case of galactokinase deficiency, cataract will be present, but hepatomegaly will be absent. But in a case of galactosemia, which is because of the deficiency of galactose 1 phosphate uridyl transferase, you will find both. Therefore, looking at the questions, I think it's very easy for you that what will be the answer here. So we are having a case with hepatomegaly and cataract. So it is going more in favor of deficiency of the GALT, which is actually the transferase enzyme, right? So this is a transferase enzyme, galactose 1-phosphate uridyl. This is the transferase deficiency which I'm talking about. And here you can see there is cataract with hepatomegaly. Please remember this. Of course, you can have other features like jaundice or mental retardation as well. So this is very important. You can say a kind of differential diagnosis. Right? So in galactokinase, we see only cataracts without any additional features. But in GALT deficiency or transferase deficiency, there are additional features as well in the form of hepatomegaly, jaundice, or mental retardation. Fine. So this is how you can reach up to the answer for this particular question. Now, then there was one question about Zellweger syndrome, and again, this is a repeated questions. Many times it has been asked, and that is related to the defect in peroxisome biosynthesis, right? So this is peroxisome biosynthesis. Clear? So this is Zellweger syndrome, and because of as a result of this deficiency, there is increased amount of very long chain fatty acids, right? So just write it like increased the enzyme, the short forms. So, right. So, very long chain fatty acids are increased in blood. This is the Zellweger syndrome, and there is a mutation in the X. This is Zellweger syndrome. Now, there is a very good question about lactulose, because usually previously we have questions which were about in lactose. We know that the component were galactose and yeah, this is lactose. Now, what is lactulose? Now, what happens if this galactose combines with fructose? Comes lactulose. Clear? So, lactulose, basic difference is replacement of glucose with fructose, right? So this is replaced, right? I think this is very basic thing. Galactose remains the same. Glucose replaces fructose, and glucose is replaced by fructose, and that makes the lactulose, right? The answer would be here galactose plus fructose. And I think if you have read about cirrhosis or hepatic encephalopathy, so this is used in treatment of excretion of ammonia from the body. So this is lactulose. Then this is again repeated questions. Many years it has been repeated. So this is a characteristic Casal's necklace, right? So this is a Casal's necklace, and I think all of you can answer is that it's a case of Allegra. So we should supplement nicotinamide, right? So nothing much to discuss in that. Another question was like CRISPR-Cas9 technology. CRISPR-Cas9 technology, and that is for actually used for DNA editing, right? So CRISPR-Cas9 technology, and that is clustered, regularly interspaced, short palindromic repeats. So that CRISPR-Cas9 for DNA editing mechanism. CRISPR-Cas9. Now, our next question was about a couple who is having a 4-year-old child, and now they complain that the child has self-mutilating behavior with poor. Now, the moment you find the word self-mutilating behavior with poor growth, sometimes there may be, gout as so gout, or what you call hyperuricemia. The moment you have this kind of picture, very classically, you can just say that this is a case of Lesch. One again topic which has been asked over the years. I think most of you must have marked it right, that the deficiencies of HGPRTase, right? So this is HGPRTase deficiency, and here you can there are two ways actually where this deficiency affects. Like one is conversion of guanine to guanine monophosphate, and another is hypoxanthine to inositol monophosphate, right? So this is inositol monophosphate, and if these two, no, these two are mediated by HGPRTase, right? So if there is any deficiency of HGPRTase, these two steps would be blocked, and what would happen these two, they will promote synthesis of xanthine, which when acted by xanthine oxidase will lead to formation of uric acid, right? So this will lead to the formation of uric acid. And since there is more production of uric acid, that is hyperuricemia, that what manifests as gout. So this is the reason why there is gout in a patient of Lesch-Nyhan syndrome, right? So this is because of deficiency of the enzyme HGCRTase. So this is Lesch-Nyhan syndrome. Perfect. So next question, again a very important question, and from a very important topic repeated over the years, and this is the starting is with alcoholic patient, right? So he's drinking since a very long time. Now he has presented with agitation, confusion, and when he inquired, it was found that he had left 3 days back, right? So there is a history of alcohol withdrawal. Yes, the moment you have any case history where there is alcohol withdrawal, 48 to 72 hours with confusion, hallucinations, tremors, think of the possibility of delirium tremens, right? So time period is very important. 2 to 3 days, no alcohol in a person who is taking alcohol since many years. Answer has to be tremens, whatever the features that this is very important. The time period will just give you a clue that you have to mark the answer as delirium tremens and nothing, right? So there can be tremors, there will be confusion, delirium, right, and hallucinations. So this is all delirium tremens. Time period very important, and that is self-sufficient to make a diagnosis of delirium tremens, right? Now, next question. This again we have already discussed about unconjugated, right? So unconjugated type of hyperbilirubinemia. You have to just think of two conditions. One is Gilbert syndrome, and the second is Crigler-Najjar syndrome. Here, think of two conditions, very straightforward thing. So you will mark the answer as Gilbert syndrome, right? Now, if there is a person in they are suspecting alcohol poisoning or excess intake of alcohol, and we need to take a blood sample to check the amount of alcohol in the blood, or what you say blood alcohol concentration. Now what preservatives has to be used while collecting the samples is simple: sodium fluoride and potassium oxalate, right? So because, and if you know the sodium, right, it inhibits enolase. Clear? By inhibiting enolase, it prevents. So utility, or this is the importance of adding sodium fluoride to potassium oxalate. So that is very important while you are saving a sample for measurement. Now there was another question, and this was about cherry red spot. And here it has been given that there is no hepatomegaly or hepatosplenomegaly. So it means there is no liver in what we are getting only a cherry red spot in the fundus in the macula. Now here, cherry red spot, the moment you find this, you have to think of two conditions. One is, another is Niemann. Cherry red spots two conditions in consideration, either Tay-Sachs disease or Niemann-Pick's disease. Now here, this additional feature will help us in getting up to the answer, whether it is a case of Tay-Sachs or whether it is a case of Niemann-Pick's disease. So if you look at the finding here, we can see that in cases of Niemann-Pick disease, we will get liver and spleen enlargement, right? So which is not present in Tay-Sachs disease, right? So the answer is cherry red spots, but without liver and spleen enlargement. So you will favor of making a diagnosis of Tay-Sachs. If patient is having cherry red spots but hepatosplenomegaly, then you would mark Niemann-Pick disease and not Tay-Sachs, right? So that is a very basic difference in terms of the organ enlargement, because otherwise you get many features almost same. Like you will have cherry red spots in both the conditions, then there is hypotonia, then there is the delay of milestones, right? Feeding difficulties. So most of the things are absolutely same. That organ enlargement help us in differentiating whether a given case of cherry red spots or over fundus is Tay-Sachs or Niemann-Pick's, right? And I think knowing that for Tay-Sachs it is the deficiency of beta hexoaminidase deficiency, whereas in Niemann-Pick's it is sphingomyelinase deficiency. Now, next question was about case history in which our elderly patient who is an alcoholic developed confusion and tingling sensation, and it was known that he is eating polished rice. Okay? So now this word is very important here, and this alcoholic word might confuse you, but this is quite evident that this is a case of neurological presentation. So this is neurological presentation, and this is deficiency of vitamin B1. So this is dry beriberi. Okay, dry beriberi. Because we know that in wet beriberi there is cardiovascular manifestations, right? So this is dry beriberi, and therefore the answer would be option B, right? Dry beriberi, there is neurological symptoms, especially paresthesias, wernicke's encephalopathy also. And as far as the wet beriberi is concerned, it is especially related to cardiovascular, like high output, heart failure, and other features. Now, there was one question about like a person who has done heavy exercise and without taking anything, he went to a party and he took alcohol. Now, this resulted in hypoglycemia. Now, in terms of biochemistry, it is being asked like what is that biochemical process which has been affected by this alcohol consumption and that resulted in hypoglycemia. So actually, alcohol, it inhibits gluconeogenesis. Alcohol, it inhibits gluconeogenesis, and I think most of you must be knowing what gluconeogenesis is. It is production of sugar from non-sugar sources, right? So from non, what are they? It pyruvate, glycerol, or some genic amino acids also. So this is, and here you can remember the mnemonic LPG. I remember it like this: lactate, pyruvate, glycerol. What is happening? There is no gluconeogenesis, so there is no sugar production, and that what is the factor behind reduction in blood glucose level, that is hypoglycemia. So that is postulated something like that. Now, another question: a young patient have pellagra-like eruptions over skin, and is having normal hydroxyindolic acid with high amino acid urea, and indole levels in urine are also normal. What could be the diagnosis here? Now, if you see the word Allegra-like eruptions, it means something is related to tryptophan metabolism, because we know that niacin is produced from tryptophan. So something is related to tryptophan metabolism, and serotonin thing is normal here, but amino acids are increased in urine. So increased amino acids in. So this is a classical case of heart nerve disease, right? So this is a classical presentation of heart nerve disease, and this heart nerve disease is actually tryptophan deficiency, right? And therefore you have the classical dermatitis as that of Allegra, and there is increased amino acids levels in. This is very important here. This is all heart nerve disease, somewhat related to Allegra, that is because of niacin deficiency. This is a heart nerve disease. The next question was very basic question, and it was vitamin A deficiency, which I think everyone can answer that it is related to white dot spot. Then there was one question about a reaction here. An unconjugated substance is converted into conjugate form. So unconjugated is converted into conjugated, and the very common substance which we discuss is actually bilirubin. So bilirubin is unconjugated, is very toxic. It has to be conjugated in the liver, and this process is actually known as glucuronidation, right? So this process of unconjugation to conjugation, this is known as glucuronidation. So I think nothing more to discuss in this. The next question is like about the most sensitive cardiac biomarker for myocardial infarction, and I think most of you can answer it very straightforward, that it is troponin I or troponin T. So troponins are the most sensitive biomarkers for myocardial infarction. So you can just take the time frame like this, start elevating somewhere between 3 to 12 hours, then peaks somewhere around 24 hours, and come back to normal by the second week. So that is the usual graph of troponins. So around 3 to 12 hours they start peaking. We will reach the peak by the end of first day, and by 2 weeks they will come back to. This is for troponins, right? So I think this finishes the biochemistry part. So in this session, in this particular segment, we have taken physiology and biochemistry, and we will take a 15 minutes break, right? So we will take a 15 minutes break. Post break, we will continue with pathology. See you on the other side of the break. Thank you. Hello, dear students. Welcome back after the break. We will start the session with MCQs of pathology. Right? So, the very first question was again from a very important topic, that is necrosis. And here, a specific mention was about a past history of acute pancreatitis. And this was supplemented by raised levels of amylase and lipase, which is further strengthening the diagnosis of acute pancreatitis. And the type of necrosis which is seen in a case of acute pancreatitis, I think all of you can answer. It's pretty forward question, that is fat necrosis. So in terms of fat necrosis, you need to just remember two entities or two examples. One is of course acute pancreatitis, and the second one is related to breast, is blunt trauma. These are the two conditions where we find fat necrosis, right? So nothing much to discuss in this particular MCQ. Now, another question was also from a very important topic, that is calcification. And here we know that there are two types of calcification, that is dystrophic and metastatic. So looking at the MCQ, we can just move forward with the discussion part. So here, patient was having fever, then he was having enlargement of lymph nodes, and then when these lymph nodes were biopsied, it was found that they were showing some necrotic tissue with calcification, right? So here, what we can just make out, the status of tissue is necrotic, right? And plus calcified. So I think all of you can answer that this is, since this is a dead or what you call degenerated tissue, type of calcification which we'll see here is dystrophic. Yeah, this is dystrophic type of calcification. And we know that in dystrophic calcification, the serum calcium levels are normal, right? So it is the tissue which is dead or dying or degenerated, and the serum calcium levels are normal. So this is a classical dystrophic calcification with normal serum calcium, right? So this is the classical presentation of dystrophic calcification, and serum calcium levels be normal here. So, and as far as the metastatic calcification is concerned, now the term is metastatic. It means the calcium is going to different places for deposition, and this is especially seen when the serum calcium levels are elevated, what you call hypercalcemia, and here the tissue is normal, right? So we can summarize the two conditions based on 2 points: status of tissues, number is serum. So we can discuss the dystrophic calcification and metastatic calcification. So in dystrophic, the tissue is either dead or degenerated, but in metastatic calcification it is normal, whereas serum calcium levels in dystrophic are normal, but in metastatic it is. I think this table can summarize the two conditions in a better way. So the moment you find any calcification in a dead, degenerated or dying tissue, it has to be dystrophic, right? Because metastatic, it occurs in normal tissues, although the serum calcium levels are elevated. Okay, so this is about the two. Now, in the case of acute inflammation, which is the most effective enzyme or most important enzyme, and that is NADPH oxidase. So that is one of the important mechanism in inflammation pathway that generates NADP plus superoxide. This is NADPH oxidase. enzyme. Now then there was a karyotype, and it was up to student to identify like what is the diagnosis based on that. Now if you look at the karyotype, you can see that all of the chromosomes are having two genes, but in 18 there is trisomy, right? So in 18 you can clearly see the trisomy, and trisomy 18 is known as, like if you write it like 18, then you can remember it like adverb. This is how I remember it. 18. So this is a typical case of Edward syndrome, and what we see in Edward syndrome actually. Now here you have to remember 2-3 points especially. One is low set ears. The ears are at a lower level. So one is low set ears. This is number one. Then number two is club foot, or sometimes you use the word rocker bottom foot, right? So this is rocker bottom foot. And the rocker bottom, the term is actually like based on one chair. The legs are something like this. Okay, so this is the rocker bottom feet chair, right? So the feet are something like this only, known as rocker bottom feet. So this is two important points for Edwards syndrome, that is trisomy 18, right? So apart from that, there are many other features, but the moment you find these two features, think of Edwards syndrome, which is trisomy 18, right? Now, then there was one question about pedigree, and now this pedigree segment is becoming important nowadays. In every exam, we see one or other pattern of inheritance which has been asked in the form of a pedigree image. So just try to make sure that you are well versed with these kind of questions, right? So now, considering the pedigree which was given in this particular here in question, so this is the male, right? And this is clear. So, and you can see, so these are actually the parents, right? You can say these are the parents here, and the female is affected. Okay? So this is female is affected, right? So it is colored, so female is affected. Now what we can see here, now this couple has 4 children. So first, second, third, fourth, and we can see that all the children are affected. So this is again male affected, this is female affected, male affected, and female affected, right? So first generation, all the children were affected. Now these children, they get married, and the offsprings which came out of the males especially, so the offsprings which came out of the affected males are normal here. So you can see the affected male is not transmitting the disease to the offsprings. Now what we can see in relation to the female, now female is again passing the disease to all the offsprings. So all, you can see here, all affected, right? So what we can just summarize from this pedigree is that if a female is affected, it is going to pass the disease to all children. Clear? So affected female is passing the disease to all children, and if the male is affected, it's not passing the disease to any children, to any child, right? It means the transmission is only occurring if the female is affected. Male has no role in passing of the disease, and this type of inheritance is known as maternal inheritance. Right? Only the affected female is passing on the disease to all the offsprings. Any number of child, everyone will be affected from affected mother. But if the father is affected, there is no risk of transmission of the disease to the offspring. So this kind of inheritance is classical or maternal inheritance, right? So again, in this image, you can see here the male is normal and female is affected. Now, all the children are affected, right? So from mother, the disease is from the affected mother, the disease has passed on to all the children. Now take the opposite thing. The father is affected and the mother is normal. See, all the children are normal. Means no transmission has occurred to the children from affected. Right? So this is classical maternal inheritance. Quite easy to understand. The only thing is that you have to apply the knowledge to the pedigree and you have to evaluate or you have to study the pedigree with concentration. And the moment you get this concept, mark it wrong. Now there was another question here. A child presented with cleft lip. The head size was small. So micro means, cephali means head. Then clenched fist, right? So clenched fist, this is important clue here. And eye abnormality. So cleft lip, small head, clenched fist, and more important, eye abnormalities. This all goes in favor of the diagnosis of Patau syndrome. Right, and here one important thing has to be mentioned about the eye abnormalities. It means the distance between the two eye is less, and at times the two eye becomes one eye. Right? So this is the classical eye abnormalities in a case of Patau syndrome. Right? So here all you can see is this is cleft lip. Right? So you can see the cleft lip here. Then here you can see the clenched fist, right? And you can see the fingers overlapping each other, right? And what is more important and what I want to stress is close set eyes. The eyes are closer to each other, and sometimes they fuse together into one. Sometimes you might see a picture in which the child is having a single eye in the midline. So that is a classical picture of Patau syndrome, right? So this is very important, right? And then you can have cleft lip, clenched fist, or small head. This is micro. Carefully, right? So you don't have to memorize each and everything. Just take the important keywords and sufficient to make a clinical diagnosis. Now, a next question, and here no other clues was given. It is just the most common type of anemia was asked in a 65 years old female. And see, there are two ways in which you can answer this question. If you don't know the answer, it is always said that go with the commoner condition. And secondly, in relation to this question, now this is an elderly female, and female, they have high possibility of blood loss, especially during reproductive age group when they were menstruating or having delivery and other things. So blood loss possibility is always there, right? And that what also is indicative of some component of iron deficiency, and therefore iron deficiency anemia seems a better answer in this particular question, right? So elderly female, possibility of iron deficiency anemia, if there is no other clues in the question. Then a next question, and again this the new question is a perfectly new question, and it's like asked for the very first time. Now here, a patient is presenting with fatigue, pallor, and weakness. So everything suggestive of anemia. And when evaluated, hemoglobin was low. Yes, case of anemia. But what additional point was given? Low reticulocyte count. And WBC platelet, absolutely normal. So it means there is some pathology which is especially affecting the erythroid line only. The WBC platelet, they are produced normally, right? There is what you are getting here, low hemoglobin. And second important point is reticulocytopenia, right? So this is reticulocytopenia, low count of reticulocytes. So the moment you get these two words, the answer has to be pure red cell aplasia. Okay? So the classical case of pure red cell aplasia, and here there is profound anemia and very low reticulocyte count, that is reticulocytopenia, and there is absence of erythroid precursors in the bone marrow, and therefore the red blood cell line cells are less in number, that is reticulocytes, and also the mature RBCs. And all other cells are normal, that is WBC platelets, they are normally produced, right? So this is pure red cell aplasia, PRCA. Now then there was one question about Bombay blood group patient. Bombay blood group patient, and it was asked like they can receive which blood group. So Bombay blood group. Now firstly we have to discuss what this Bombay blood group is. Now this Bombay blood group, and as the name suggests, Bombay, so it was discovered in Bombay, right, in 1952 by Dr. Y.M. Bhende. So this is known as Bombay blood group because it was discovered in Bombay, and the nomenclature is small h, small h, and here there is absence of H. So there is absence of H antigen, and sometimes we write it as H minus, right? And this is like blood group O without H antigen. So this is somewhat like blood group O without H antigen, and therefore only a person with OH negative can give blood to Bombay blood group patient, right? So they can receive the blood from the same blood group, right? So they can receive the blood from the same blood group persons, that is Bombay blood group, which is H, small h oblique h or OH negative, right? So this is Bombay blood group. Although they can give their blood to anyone, but they can receive only from the same blood group. That is very important here. They can donate to anyone, but they cannot receive from everyone. They will simply they'll simply take the blood from the same blood group, that is OH negative, right? So this is a new question, and yes, a very rare kind of blood, and principally seen in India. It is mainly seen in Bombay. That's why it's Bombay blood group. Now, a question starting with HIV patient with fever, cough, weight loss, and then biopsy image is given here. So what could be the likely organism? Now let us look at the biopsy image. Now what you can see here, you can see a cell something like this, and okay, so this is the nucleus actually. Okay, this is the nucleus, and surrounding the nucleus we can see a white rim, so that is known as halo. right? And after that, there is a line. Similarly, you can see here something like this. Okay. See one more cell here, although not that here. These are known as owl eye inclusion bodies. These are known as owl eye inclusion bodies. And I think most of you, the moment you find the word owl eye, you can answer that this is cytomegalovirus. So in older times, they used to simply ask like owl eye inclusion bodies are seen, and the answer was quite easy, CMV. But nowadays, they're just complicating a slightly easier pattern by giving histopathological images, and then it becomes a little difficult unless and until you know the image properly, right? So this is the concept behind that, like how to identify. So how to identify owl cell. What is important for you to understand here is there is a clear right? This is how we identify the uh, owl cell, owl eye cells or owl eye inclusion bodies suggestive of CMV. Okay, so classical CMV picture, and in many discussion forums you see a classical image like this, right? So this is the typical owl's eye inclusion bodies suggestive of CMV. Now, next question. A patient has joint pain, abdominal pain, rashes, and hematuria. Right? So, that is blood, is right. So, he's having joint pain, abdominal pain, blood which is coming in urine, and he has some rashes over the lower limbs, especially. This is a classical presentation of inox-Schonlein purpura, right? So, this is classical presentation of inox-Schonlein purpura. You can see abdominal pain, joint pain, and purpuric rash, which is almost seen in all the patients. Again, this is a very classical word here, purpuric rash, right? You can see the rashes on both the lower limbs, and this is seen in almost every case, right? And then there is hematuria not coming in vein, right? So this is classical presentation of Schonlein purpura. Clear? HSP. So moving forward to next question. Again, this we have discussed in biochemistry, and I have just slightly twisted the point, and here it is being written like earliest marker for which actually exists in a case of myocardial infarction. The answer is IMA, that is ischemia modified albumin, right? So this is IMA. So earliest is IMA, right? So you can see here ischemia modified albumin far before any other marker which is elevated. And after IMA, if the next one is myoglobin, but again, myoglobin is not, myoglobin is one of the earliest marker to rise, but it is not specific for MI. So if it raised, then you cannot say the person is having myocardial infarction. So it is not specific. Okay. Then there was a question in which a gross image of testicular mass was given, and this was importantly in a 30 years old male, right? So this is the gross specimen, 30 years old male of a testicular pathology. And this is, if you can see here, the cut surface shows no evidence of necrosis or hemorrhage, right? It shows no evidence of necrosis or hemorrhage, and that goes more in favor of the diagnosis of seminoma, which of course carries best prognosis amongst testicular tumors. So what is more important for you to remember is no necrosis or hemorrhage in the pathology, right? So that favors the diagnosis of seminoma. Clear? This is the important line, I think, which you should remember. There is no necrosis or hemorrhage in the testicular pathology. This goes more in favor of seminoma, and of course, it is one of the most common tumors of testes, especially the germ cell tumors. And classically, the age is around between 30 to 40. Right? So this is seminoma, and yes, female or ovarian counterpart is this. There are few things which you should remember for seminoma. So this next question we have already discussed in medicine about the long-term glucose control, and I think most of you can answer that this is glycosylated hemoglobin, right? So this is long-term glucose control. This just gives us an idea about the blood sugar, average blood sugar levels in previous glycosylated hemoglobin. Now, this question we have already discussed unconjugated bilirubin. The answer has to be Gilbert or Krigler-Najar. Both can come here, right? So, in this question, both can come, and I think for either of the options should be excluded to make it more perfect. So, Krigler-Najar can also come here. Now, pneumoconiosis, which is because of inhalation of cotton dust. I think most of you can answer. This is bassinosis. So, cotton dust. Then, primary lymphoid organ. We have already discussed this. So, primary lymphoid organs, you need to remember only two. One is thymus, and is bone marrow. Need to remember only two. We can take a break. In fact, not 15 minutes. Mistake. I think we can continue. The power has come. Okay, so primary lymphoid organs we have already discussed, thymus and bone marrow, and apart from that, everyone is secondary lymphoid organ. So here in this, there is no concept of antigen involvement, and these are actually related to production. Now, next question was about carcinoid tumor, and it was like the tumor marker which has been asked for carcinoid tumor. So this is again 5-hydroxyindole acetic acid excretion in urine, and clinical symptoms point of view, patient presents with flushing, with sweating, right, diarrhea or bronchospasm. The classical presentation of carcinoid tumors, which are because of excessive production of serotonin, that is 5-hydroxytryptamine. Right? So this is classical presentation. Tumor marker is urinary 5-hydroxyindole acetic acid. The next question was about acute phase proteins, and it was asked like which of the acute phase protein decreases in acute inflammation, because there are many acute phase proteins which elevate, there are some which decreases, and classical which we always check is the CRP, which actually increases, right? So this is CRP, and many times you must have seen in prescriptions, like whenever we are evaluating infections, we write for CRP, ESR, etc. Right? So this increases, but the one which decreases actually is albumin. So not the answer actually. So albumin, it decreases, and haptoglobin, ferritin, they all increase. So the acute phase proteins which actually decrease in infection or inflammation, they are the albumin. Albumin is one of the important acute phase proteins which decreases. Now we'll move on to microbiology, and the very first question was from sexually transmitted diseases. Here, a patient presented with painful genital ulcers and associated with enlarged, and this was after unprotected sexual act. Now, what is the diagnosis? Now, here the important keyword is painful genital ulcer, right? And this goes more in along with the enlarged. Now, it goes more in favor of chancroid, right? Because here uh, there are multiple genital ulcers which are extremely painful, and these are non-indurated, right? So the base of the ulcer is soft, and there is enlargement of the lymph node. Sometimes they separate, and they also the uvo, right? So this is a classical case for chancroid. Now it was having fever with chills, and then the peripheral smear was shown. And the moment you look at the peripheral smear, I think all of you can answer this question. So this is a classical case of falciparum malaria, right? And what you can see here, if you look at the image properly, you can see something like this, right? So something like this, and this is known with different names, like sometimes it is known as headphone appearance, something like this. It is also known as smiley. So this is classical for Plasmodium falciparum. Okay, classical. Then mechanism of action of diphtheria toxin. Now, diphtheria toxin actually inhibits protein synthesis by affecting the ADP ribosylation of the elongation factor 2. So it inactivates elongation factor 2, and it prevents protein synthesis by the ribosomes, and this leads to cell death. So this is the mechanism of action of diphtheria toxin, especially affecting the elongation factor 2. This is important for in terms of diphtheria toxin. Now, vector for scrub typhus, which is Orentia shushugamushi. This we have already discussed before, and this is the mite. And the condition is, of course, scrub. Previously, this is known as Ischia, but nowadays we use the word Orentia. Then next question, there was outbreak of diarrhea, and patient was having stools which were of the consistency or appearance of rice water stools, and the organism, it was showing darting motility. And then the culture media, the growth of the bacterium on the culture media is shown. Now, which organism can be this? Now, if you see, if you just gather few points here, there is diarrhea, rice water stool, darting mortality. All these are sufficient to give an impression that this is a case of cholera. Rice water stool, this is cholera, and cholera is caused by Vibrio cholerae, which shows darting motility, right? So darting motility. Now, if you look at the culture plate, this is actually TCBA, and in the culture plate we can see yellow colonies, right? So we can see here these are yellow colonies, okay? And this is because of fermentation of sucrose, right? So these are all yellow colonies of Vibrio cholerae. Yeah, so this is a classical question related to Vibrio cholerae, and we can see this is a, you can see these are all yellow colonies which are classically because of fermentation of sucrose. So sucrose fermentation, and this is thiosulfate citrate bile salts agar TCBA. Okay, so this is Vibrio cholerae. Now, normal flora of conjunctiva, it means which microorganism can be found in the conjunctiva in a normal person as well, and the answer is Staphylococcus epidermidis. Now, this is not the only organism which can be found. The list is very long, so just remember few, especially Staphylococcus epidermidis, and then Corneobacterium can be normally found as well, right? So please remember these two, or Propionobacterium acnes also is one. So at least remember these two. These are the normal flora of conjunctiva. Again, a question from a repeated topic, but the presentation was slightly different. Here, a person was from high fever, his peripheral blood smear was given, and it was like what treatment you need to do. So if you look here, you can see a classical banana shaped gametocyte, right? So this is a classical banana shaped gametocyte, and you can see, you can also see some whole forms or rings, like this is what headphone appearance. So this is a classical for Plasmodium falciparum or falciparum malaria. This is falciparum malaria. Clear? And what we need to give, we can just give artemisinin based combination therapy. That is what is the answer for this question. Now, this one question we have already discussed. Here, our patient presents with fatigue, tiredness, and what we found is that he's having low hemoglobin and low reticulocyte, and there is a decrease in erythroid precursors, right, without involving the WBC or the platelet precursors. So low hemoglobin, low reticulocyte count, specifically affection of the erythroid precursors in the bone marrow. Straightforward, your diagnosis has to be pure red cell aplasia, right? So just remember this question. Now, this is one more question which we have already discussed. I have slightly changed the presentation here. So patient was presented with a low CD4 count and he was having pneumonia. Now we have done Gomori methamine silver staining of the bronchoalveolar lavage, and this was the image, right? So this bronchoalveolar lavage, and Gomori methamine silver staining. And what we can see here, we can see a classical, broken or depressed ping pong or table tennis ball, right? You can write table tennis ball appearance. Okay, this is classical for pneumocystis carinii. We know that pneumocystis carinii causes pneumonia in a HIV infected person. So this is classical, and bronchoalveolar lavage is an ideal, substance for demonstrating this pneumocystis carinii. So if you look here, see these are the cells, and there is some. This looks like a depression in the center, similarly something like this. So this is a classical picture for pneumocystis carinii, right? So it looks something like this, right? Gomori methanamine silver stain. You will see this kind of picture. So think of pneumocystis carinii. Okay. Then another question was about occurrence of Kaposi sarcoma with respect to the CD4 count. So when Kaposi sarcoma will develop in a patient of HIV, especially when the CD4 count falls below 500. If the CD4 count is below 500, patient will develop an HIV infected patient will develop Kaposi sarcoma and also oral candidiasis, which is known as thrush. So if you can just memorize this whole table, I think it will be very important, because many times we have question from this segment, and with respect to a particular condition, it has been asked like what will be the count in an HIV infected person. Right? So this is one important thing. For Kaposi sarcoma, it is less than 500, and sometimes they ask about the MAC, that is Mycobacterium avium complex, where the CD4 count is less than, also very important, or CMV retinitis, cryptococcal meningitis. So this particular segment is also important in terms of pathology. And we just discussed about pneumocystis carinii or pneumocystis zerovici pneumonia that is seen if the CD4 count is less than 200 cells per milliliter. Okay, just remember these 3-4 conditions which are very important from exam point of view. So there is one more question, and here HIV patient with cough, fever and pneumonia, and then the biopsy is given. What agent it could be? Again, it's this we have already discussed, and you can again mark out the classical owl eye appearance, right? You can see the classical owl's eye inclusion body. And the moment you find this kind of picture, I think straightforward you can jump on to CMV. This is a classical, again you can see this one is a classical owl eye. Very easy to identify. So this is classical CMV. So you can see here, this is the classical owl eye appearance in CMV. Then next question, a patient was having diarrhea, and more importantly, there was flask-shaped ulcers, and was parasite which was having quadrinucleate cyst. A quadri means 4. So the parasite was having 4 nucleus within the cyst, and more importantly, there was flask-shaped ulcers. So the moment you get this word, the diagnosis is amoebic arthritis. Yeah. So this is because of Entamoeba histolytica, right? So this is because of Entamoeba histolytica, and for that we give amoebic enteritis, or you can say amoebic dysentery. So here you can see in the image, you can see a classical cyst. It is having 4 nucleus, 1, 2, 3, 4. So quadrinucleate cyst. Then there was one question about identification of the fungus, and here what we can see, there are, right? So this is 1 septa, this is 2, this is 3, and then this is classical presentation of epidermophytome. And when we say it's club shaped septate, which may be from one, these are septations, right? So this is all septate, right? So this is a classical epidermophytome. So description goes like club shaped, multi-septate, macroconidia, of course, and there are no microconidia here. So this is epidermophytome. Clear? Now, for starting pharmacology, we can take 15 minutes break, right? So then we will take pharmacology section. So we can take a 15 minutes break here, right? So see you on the other side of the break. Thank you. Welcome back, dear students. In this session, we will start with pharmacology, right? So, in pharmacology, there was one question in which a person was on metronidazole therapy, and then later on, he attended a party where he took alcohol. As soon as he took alcohol, he developed intense facial flushing, nausea, vomiting, headache, dizziness, palpitations, and hypotension. So, what is the reason for this? So, here you need to just note down two things. Number one, metronidazole, and second thing is alcohol. Right? And if you look here, the patient developed flushing. Flushing means redness, nausea, vomiting, headache, dizziness. Palpitations means a sense of heart beating. Hypertension is low blood pressure. Now, this is actually a type of drug interaction, and this particular phenomena is known as disulfiram reaction, because the reaction is identical to a situation where a person who is on disulfiram drinks alcohol, right? So actually what happens now, this disulfiram is a drug which is given to a patient, addict of alcohol. It is given to a patient who is alcohol addicted, and this is used for de-addiction, right? So this is for de-addiction of, right? So if a person is on disulfiram, he will not he will not take alcohol, because he know that if on disulfiram he is taking alcohol, there will be severe reaction like flushing, nausea, vomiting, palpitations, and all those things. So it is a compulsion for the patient who is on disulfiram to avoid alcohol. So here in this case, the patient is not taking disulfiram, but he is taking metronidazole, and along with this drug, if he is taking alcohol, similar kind of reaction is appearing as that with disulfiram and alcohol. So therefore, this is known as disulfiram like reaction, and this is drug plus alcohol leading to all these manifestations, right? So this is a classical disulfiram reaction. And not only with metronidazole, there are numerous cases which can have these kind of clinical presentation. If the patient is on those drugs and if he take alcohol, he will have all these effects, right? So of course, metronidazole is one important drug which can produce disulfiram type reaction. Okay, next question. Now, which drug can have, or which can be used for hepatitis B infection and also for HIV infection? So it can control, or it can act against two viruses, either hepatitis virus or HIV virus, and that drug is tenofovir, right? Tenofovir, it can be used against both hepatitis B virus and HIV virus, right? So it can be used in both the scenarios, in a case of hepatitis B infection or in a case of HIV. Tenofovir. Then a person with diabetes was taking some drug, and he forgot to take meals before going to the gym. During workout, he collapsed, and when his blood sugar was measured, it was 50 milligram per deciliter. Now, which drug can be responsible for these hypoglycemic episodes when taken as monotherapy? Right. So, what you can just take out from this point is a known case of diabetes with some drug, so on some agent, and then skipped meals, and later on developed hypoglycemia. Right? So this is the usual uh, things which are given in this question. And monotherapy means single drug. So he is taking only that drug. He is not taking any other drug along with that. So what that drug is, the one which is responsible for this kind of hypoglycemic side effect, and this is the one which will promote release of insulin. So oral antidiabetic drug which promotes release of insulin is liable to cause hypoglycemia. So this we have already discussed in medicine, and the answer would be here glimepiride, right? So this is glimepiride. So hypoglycemia is a complication. The side effect, you can remember, like hypoglycemia. Gliptins can have that side effect, but very less possibility as compared to glimepiride, that is sulfonylurea. Now, anti-cancer drug, the side effect of which is hand and foot disease. So which anti-cancer drug can cause hand and foot disease? The answer is capecitabine. So capecitabine can cause hand and foot disease, right? So this is capecitabine, which can cause hand and foot disease as a side effect. Then there was one more question on anti-diabetic drug. So here a female who is on anti-diabetic therapy for the last 10 years has few episodes of vaginal candidiasis, and therefore which anti-diabetic drug should not be given to such a. So he is already having vaginal candidiasis, and there is one drug which has high tendency of causing genitourinary infection or vulvovaginal candidiasis, that is canagliflozin. So canagliflozin, which is a member of SGLT2 inhibitor, should not be given in a lady who is prone to get vulvovaginal candidiasis, because it is one of the side effects of this drug as such. So this is canagliflozin. This is one of the side effects of canagliflozin. Now, which anesthetic agent can be given which is preferred for total intravenous anesthesia? Now, this is propofol. Now, what is this term total intravenous anesthesia? Now, as the name suggests, total intravenous. So, the agent is given, the anesthetic agent is totally through IV lines. There is no use of gas, even nitrous oxide, except oxygen, right? So gases are not used. The anesthetic agent is given through the IV line only. So total intravenous anesthesia, right? So this is the concept of total intravenous anesthesia. The agent is given through the IV line only. No use of gases except oxygen. Now, this is again a repeated question. A person is going cancer chemotherapy with methotrexate. Now, what is the action of methotrexate? We have already discussed that it inhibits DHFRase, that is dihydrofolate reductase enzyme, and that hampers with the synthesis of DNA. Now, a patient who is a known case of hypertension had myocardial infarction and he developed migraine. Hypertensive patient having myocardial infarction, now having migraine. In such a case, which drug should not be given? So, if there is a past history of myocardial infarction never give triptans. Never give sumatriptan in a case of migraine who is having a past history of myocardial infarction, because they have a tendency to cause vasospasm. Right? So that is coronary artery vasospasm, and therefore one who is already having a past episode of myocardial infarction should not be prescribed this drug. Right? So this is sumatriptan should not be given to a case of migraine with previous history of myocardial infarction. Now, there was one question about dose response curve, and here it was shown that one drug is given alone, and in another setting it was given with some another drug, right? So here it was isoprenaline which is given alone. So this is isoprenaline, right? And this is isoprenaline plus propranolol combination. So now what we can interpret from this DRC. Now if you look here, in DRC we usually discuss two terms. One is of course the efficacy, and second is efficacy is the maximum response achieved, and second is potency, which is the amount of drug needed to produce a certain desired effect. Right? So we will be discussing more of potency in this particular question. Now in DRC, if the drug is more on the righter side, it is less potent. So more on the right, you can say it is. So what you can see here, a drug which was given singly was more potent, but when it was given with another drug, its potency reduced. So it is just because of the concept or the phenomena of antagonism. Now this another drug which has been given, it is reducing the potency or effectiveness. So this is actually a antagonist. And this is which type of antagonism? This is competitive, because we need more amount of drug. This is actually amount, right? So this is this axis we are taking amount. So suppose here if this was suppose 25, now here it is somewhat 50. So to get the same effect, we have to almost double the dose, right? So this is because of competitive antagonism, where we have to increase the dose of the substrate so as to get the effect. So this is a classical case of competitive antagonism, and here propranolol is a competitive antagonist. So this is competitive antagonist of isoprenaline, and therefore it is reducing its effect, and to get the effect we have to increase the dose of isoprenaline. So this is a very beautiful concept of competitive antagonism, which is very well shown on this DRC, right? So this is competitive antagonism. Now there was a question about one drug, rivaroxaban, and it was like about the mechanism of action of rivaroxaban. So this rivaroxaban is a inhibitor of factor 10A. Right? So this rivaroxaban, it is an inhibitor of factor 10A. Then there was a patient of absent seizure who is on ethosuximide. So what is the mechanism of action of ethosuximide? Now these ethosuximide, it actually acts on the calcium channels. So it actually inhibits the T type of calcium channels. Yeah. These are the calcium channels, and there is inhibition of the T type of calcium channels. That is an important action, ethosuximide, right? So T type of calcium channels. That is mechanism of action of ethosuximide. Therefore, it reduces the generation of those responses for epileptic fits. And this is one repeat question where a young female is looking for effective post-coital pill, and within 72 hours we can give levonorgestrel. So within, and you have two options: either you give 1.5 milligram stat, or you can give 0.75 milligram 12 hours give in any manner. Now, a patient has undergone surgery and requires the drug to reverse the muscle relaxation which was used during the surgical procedure. Now, which drug is used for neuromuscular, for the reversal of neuromuscular blockade, and that is neostigmine, right? So there are many agents which can be used for neuromuscular block reversal, and especially neostigmine or physostigmine or pidostigmine. So neostigmine is important here for reversal of neuromuscular blockade, which actually resulted in muscle relaxation. The reversal. I think this is a repeat question we have already discussed, is that a pregnant lady has been told to take folic acid supplement, and if we are giving folic acid supplementation, we are trying to minimize the chances of neural tube defects. Patient was started on ATT for tuberculosis, but he is experiencing decrease in visual activity, acuity, or color blindness. So which agent is responsible? Now I think most of you can answer it quite easily, like visual side effects, just a complication of ethambutol, right? So since ethambutol can affect visual acuity and other things, so it should not be given to children's less than 5 years. Now the reason is very obvious, because they are not in a position to notice these visual disturbances. So not be given to less small age children, because they won't be able to report the visual disturbances, and by the time we realize that, much of the damage must have been already done. So don't give ethambutol to children less than 5 years of age, just because of this particular complication. Now again, a question, this is a repeated question in different format. So a patient developed high fever, headache, then confusion, altered level of consciousness, and there is a history of travel to malaria endemic region, and then he's having jaundice, anemia, dehydration. Then this is all history of malaria, falciparum malaria. And what is important here is the blood smear, which is showing a classical Plasmodium falciparum. And for that, we need to give artemisinin based combination. So this is enough for pharmacology, and just give me a 5 minutes break, and I'll take another file, and in which we will start with forensic medicine. Just a few minutes. This file is over, and I need to open the new file. Right? Just give me a break. See you very soon. Hello, dear students. Welcome back. We will start this session by forensic. Now, the very first question was about a test which has been banned by the Supreme Court of India, and this test was actually the two-finger test, which was done to check virginity, and now it has been told by the Supreme Court that anybody who will do this will be held guilty of misconduct. Right. So this is no longer advocated for virginity testing. Right. So two-finger test is abolished nowadays. Now, moving forward to another question in which it was mentioned that few people they were sleeping in their room which was closed in winter. So door and windows everything was closed, and they have lit a coal stove. And when next morning it was found that all the four people they were dead. Now, what could be the finding if you do post-mortem examination? So here, firstly, we have to understand that what is the mechanism for the death of all those people who were sleeping with this lit coal stove. Now, what happens if the room is closed and if coal stove is releasing gas, and there is buildup of carbon monoxide in the room, right? So it's a kind of closed chamber, and this just builds up the volume of carbon monoxide in the room, and the persons they will develop something like carbon monoxide poisoning, right? So that what is the cause of the people over there. And here, if you know that, we'll find some anemic type of hypoxia. Anyway, so coming back to the forensic thing, if there is carbon monoxide poisoning, what kind of hypostasis would you see? This is cherry red skin or cherry red viscera. Now, how it looks like, how it actually looks, if you see here, this is the on the lower side, this is the usual post-mortem hypostasis which we see in a body who is not exposed to carbon monoxide. So here it is something like purplish, red to purplish. But if you see post-mortem staining in a case of carbon monoxide poisoning, you will see that there is cherry red. Right? So this is the cherry red post-mortem staining, and this suggests that there is carbon monoxide. There is death because of carbon monoxide poisoning, right? So this was the question. This was the actual scenario, and the answer would be cherry red skin or cherry red viscera. And that the reason is that there was carbon monoxide poisoning as the room was closed and the stove was burning. Now, this is the next question is again a repeat question. We have already discussed it, that contraceptive failure, MTP, can be done till a period of 20 weeks, right? MTP because of contraceptive failure till a period of 20. Now, the next question was about like a person's son was missing, and then later on his dead body was found somewhere. Now, how you will identify the dead body, that the body which has been found is actually the son of that person, right? So if we wish to establish the paternity, we can go for DNA analysis. Right? This is paternity testing. Establish that yes, the body which has been recovered is biologically related to the person who is claiming to be his father. So is the biological father or not, that we can ascertain by the paternity testing by DNA analysis, right? So this is paternity DNA test. Now then there was one image of eye, and some blackening was noticed in the sclera, and this was asked like, what is this? So this is actually a classical tachynoir which we see if person dies with eyes open, then we can have these kind of black, shadows or around the iris, or especially in the sclera, right? So this is all tachynoid, and this suggests that there is the eyes, they remain open, there is exposure to the atmosphere. So this is tachynoid, and this is because of drying or desiccation of the exposed conjunctiva. Right? So if the eyes remains open after the death, then there is formation of tachynoid, which are usually brown to black in color. So this is tachynoid, right? Even if you can look here, this is tachynoid. Then if there is death due to drowning, we see relaxation in majority of the muscles, but some group of muscles may lack this primary relaxation and they will show rigor soon after death. Now this is known as cadaveric spasm, which is also known as instantaneous rigor. So this actually means any group of muscles. Now this is because of a case of drowning. So we might have weeds in the hand. So what happens, like if a person is drowning, then he will try to save himself and he might catch some weeds, something like that. And since the muscles of the hand were in state of action at the time of death, they instantly pass into a state of rigor with all those weeds in the hand. So that is known as instantaneous rigor or cadaveric spasm. So this is a classical picture in a case of drowning, antemortem drowning. So cadaveric spasm. Now there was a question about calculation of the total body surface burnt area as per the Wallace rule of 9, and here it was mentioned that a lady has burn injuries involving both of the upper limbs, front of chest and front of abdomen. So what is the total burn surface area? So to calculate these kind of numerical questions, firstly you have to understand that what is Wallace rule of 9. Now here the body has been divided into 11 areas and value 9 has been allotted to them, right? So it becomes 99, and 1% is kept for genitalia or perineum, so it comes out to be 100, right? So you should know the 11 regions where the body has been divided in, has been allotted 999. So if we see here, we have to consider both anterior and posterior, right? So one is head and neck, both anteriorly, posteriorly. Second is upper limb, you can say right. Third is upper limb, you can say left, right? So these are also allotted 99%. Then fourth is the front of chest. Fifth is back of chest, right? Sixth is front of abdomen. Seventh is back of abdomen. Clear? So these are 7. Now we have to add 4 more. So eighth is front of right lower limb. Ninth is back of right lower limb. Then 10th is front of left lower limb, and 11th is back of left. Right? So we have got the 11. Every one is having 9%. 1% is of course reserved for the genitalia, right? So this is the remaining 1%. So this is how we will get the exact 100%. Now coming back to the question, what has been given in the question? The question states that both upper limbs, right? So both upper limbs means both upper limbs. Then front of chest. Front of chest is this. And front of abdomen. So front of abdomen is this. So it means there are 4 areas of 9%, and therefore the total burned surface area will come out to be 36%. Right? So this is Wallace rule of 9. We have divided the body areas into 11 segments having 9% each, and 1% is of course reserved for the genitalia or perineum, right? So this is how you can calculate the burn surface area. So please be well versed with this particular concept. Many times it has been asked in the past also. Now, next question. A police took few people in custody and one of the person died in police custody. Now, in such a case, who will do the inquest? So we know very well that inquest, which is actually the investigation into a cause of death. So this is investigation into the cause of death. Usually it is done by police, but if there is death in police custody, or times you might have the word lockup, then judicial magistrate will take up the charge of doing inquest, right? So in case of police custody, it is judicial magistrate. Even in case of dowry death, judicial magistrate will do the inquest. Now, a patient was brought to the hospital with features of arrhythmia, tachycardia, but most importantly, there were multiple scratch marks over the patient. Now, which drug abuse case is this? Now, here you are getting 2 clues. One is scratch marks, and second is sympathetic overactivity. So, this is cocaine poisoning. So, again, scratch marks, you can think of Magnan's symptoms where patient feel that bugs are crawling under his skin. Bugs are crawling under skin. So tactile hallucinations. So this way you can make it as a case of cocaine overdose. Next question. And again, if you see a case of alcoholism and you find there is alcohol withdrawal and post 48 to 72 hours with delirium and tactile hallucination, I think there should be no confusion whatsoever in labeling this case as a case of delirium tremens, right? So alcohol withdrawal, right? Time duration is very important, 48 to 72 hours. And then here in this case, he is having delirium, tactile hallucination, right? This is tactile hallucination here. So all favoring diagnosis of delirium tremens. Now, next question. A patient was having fear of tall building going up to heights. Now, what is this known as? Of course, there is fear. What is this phobia of heights? Phobia of heights is known as acrophobia, right? So, the person fears to climb to height, right? So that is acrophobia. No, one should not confuse it with agoraphobia, which is fear of open places or crowded places from where the escape is not easy, right? So acro should not be confused with agora, open places or crowded places like railway stations, etc. Clear? So agoraphobia